So I shall share my presentation. Okay. Uh, Today we are going to talk about mainly about strong opioids. Um, this is not going to be a lecture. This will be an interactive session. So I will be discussing patient stories, and I hope to get your comments so that we can go forward. And we will discuss the commonly used strong opioids, mechanism of action of opioids. And when you use opioids, there will be many problems in the practical aspects. And side effect is something which we have to definitely cover. So I hope to cover all this. So as you know, the WHO analgesic ladder, from the second step onwards, we have opioids. So the second step is for the opioids for mild to moderate pain or weak opioids. And third step, you can see it's opioids for moderate to severe pain or strong opioids. So I'm starting with a patient story. So what is the main problem this patient is experiencing from his face? Can any of you comment? You can unmute and speak.
Pain.
Yeah. You can see that he has severe pain.
So
So,
I feel it's trigeminal neuralgia or something kind of facial pain.
okay, thank you. This is a 56-year-old man with carcinoma of the larynx. Actually, he attended our clinic with a severe pain. He was telling that it is 10 by 10, and there is no radiation, and he was unable to sleep for the last 2 weeks, and he was in such a misery. Uh, so, how will you manage if a patient comes to you, to your clinic? Anybody?
Carcinoma plans, pain around neck, tender thin shrapnel radiation.
Sir,
So,
according to me, I'll try all my efforts to, if at all there is some, uh, from pain physician point of view, if there is some blocks can be made, we can give some blocks, or else right from starting from all other pathways of all the pain pathways can be, we can try all other drugs to alleviate his pain. Right from paracetamol till morphine. I know paracetamol definitely it won't help, but as it acts in a different pathway, I'll try right from paracetamol till morphine, whatever is there, round the clock. Last time, Madam told, round the clock medications, along with some fentanyl or buprenorphine patches. And if at all there is some ganglion which can be blocked, which can alleviate his pain, I can try neurolysis of these ganglion. Whatever can be done, which can help the patient, we can try all the pathways, sir. I won't go through WHO pathway. WHO ladder we can use, sir, but it is very severe with bar score of 10. So I
yeah,
thought, we should try our maximum level best to alleviate his pain in whatever pathway it may be.
okay. Tell me if there is something in chat. Can you read out?
Yes, sir. Dr. Ivanish have told about usage of morphine.
Mm-hmm.
Dr. Dumkumari said like admit first.
Okay. Okay. Thank you all. Thank you, Dr. Gautam. You have
Actual.
another quote of a pain physician. So for most of us who are running palliative care services,
That's way louder painkillers.
somebody is speaking, Rajlashmi. Can you mute?
I will mute it, sir.
Yeah. Uh, okay. What most of the palliative care physicians do, uh, you can see he's smiling after maybe about 45 minutes or so. So what made this difference? He's able to, what made this magic? This is intravenous morphine trial or intravenous morphine titration. Okay, so we will see what is intravenous morphine titration. So this is, you will give injection morphine 1.5 milligram at every 10 minutes interval. So the strength of ampule which is available to you might be different. For us it is 15 milligram in 1 ml. So we dilute 1 ml of morphine with 9 ml of normal saline. So total 10 ml which contains 15 milligram of morphine. So each 1 ml contains 1.5 milligram of morphine, and you will give 1.5 milligram at 10 minutes interval. What is the immediate side effect that you are expecting with the first dose of morphine? Anybody?
So Dr. Dumkumari said nausea and vomiting. Dr.
Yeah.
Archana also said vomiting.
Yeah, thank you. So we have to expect some nausea and vomiting in opioid naive patients. So you have to give an anti-emetic.
Known case. Hello.
Yeah.
Dr. Mahesh Mehta.
Yes, sir. In the known case of CA larynx, so there will be some difficulty of respiration. So morphine produces the another means respiratory depression. So the patient, the doctor should be concerned about the respiratory problem also.
Okay. So that's a real concern for the professionals, but we will come to that later. Okay. So injection metoclopramide 10 milligram IV, because nausea and vomiting is the first thing which is going to occur with 1.5 milligram of morphine. So you will first give injection metoclopramide 10 milligram IV followed by injection morphine 1.5 milligram at 10 minutes interval. And what is the endpoint or the point at which you will stop the intravenous morphine trial? Either patient has satisfactory pain relief or patient is drowsy, whichever occurs first, you have to stop it. So sometimes all the pains are not opioid responsive. So patient may develop sleepiness, then the patient has pain relief. So you have to stop once the patient is drowsy. Or if the patient is not drowsy and patient has good pain relief, then you will stop. So for giving intravenous morphine trial, you can make a chart like this, which include time, pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy or not, and what is the dose of injection morphine. Suppose this patient came at 10 o'clock and you assessed pain score, it is 10, blood pressure, respiratory rate, pulse rate you recorded, the patient is not drowsy, then you will give first dose of injection morphine. Then after 10 minutes, you will assess the pain score. Now the pain score is 7. You will chart the vitals and you will look, is the patient drowsy? No, patient is not drowsy. You can give another 1.5 milligram. So you will continue to give this until the patient has satisfactory pain relief or patient becomes drowsy. So this patient received 4.5 milligram of morphine. You can see this. And now his pain score is 1. The patient is not drowsy. So you can stop the trial or intravenous morphine titration. So this is how intravenous morphine titration is done. So this patient had good pain relief with 4.5 milligram of morphine. And is this procedure an inpatient procedure or outpatient procedure? Intravenous morphine titration.
So before Dr.
Patient.
has raised her hand.
Yeah.
Sorry, this is my mistake.
Yeah.
Sure.
Okay.
Dr. Bismi have answered as inpatient, sir.
Okay.
Inpatient.
Okay. So for your information, this is not an inpatient procedure. You can do it as an outpatient procedure. We at least get 1 or 2 patients every day for intravenous morphine titration. So it can be done as an outpatient procedure. So this patient received 4.5 milligram of IV morphine and you want to send the patient home. So you have to convert it into oral morphine. So what are you going to do with conversion? How will you convert if the patient is not on any opioid or opioid naive patients? This patient received 4.5 milligram of IV morphine, and how will you convert to oral morphine?
Multiply with 10. Dr. Avanish have replied.
Okay. Anybody else? Okay. Yeah. One more response is there.
Divide into equal 4 hourly doses. IV to oral is 1:100.
Okay. So thank you for your responses. So here, Dr. Rajagopal and his team, when he was practicing palliative care in another institution, they developed this method, and they converted IVs to oral almost 1:1. So suppose this patient received 4.5 milligram of IV morphine, and they converted it into 4.5 milligram oral morphine. So, but from the practical point of view, you have to understand the strength of morphine tablets available. So we have 10 milligram tablets, which can be broken. So you can make it a half, and you can administer 5 milligram. Okay. So this patient you can give 5 milligram of oral morphine. So this is how you will administer morphine. It has to be administered every 4 hourly. So you can see the first dose is given when the patient wakes up, followed by 10 a.m., 2 p.m., 6 p.m., and at bedtime usually double dose is administered. And you can give half or 5 milligram of morphine as and when needed if the patient has severe pain. So you can see 5 times morphine is given. Even though we say it is 4 hourly, it will be difficult for the patient to take early morning dose at 2 a.m. So usually the patient will be sleeping, or they need to be woke up for taking morphine at midnight. So in order to avoid that, you will give a double dose. This is how it is usually practiced everywhere.
Sir, Dr. Avanisha commented, can you repeat IV dose titration once again?
Okay. So it is intravenous morphine titration. You can take 1.5 milligram of injection morphine every 10 minutes. So you will continue to give this until the patient has satisfactory pain relief or the patient becomes drowsy, whichever be the first you have to stop. And the patient, suppose this patient has not taken any opioids previously, then you can convert the same IV dose to oral dose. This patient has taken 4.5 milligram of IV morphine, so you will give 4.5 milligram orally every 4 hourly. But from a practical point of view, 4.5 milligram tablets are not available. 10 milligram tablets are available. So you can break it into 2 halves and give 5 milligram every 4 hourly. I hope it is clear. So many palliative care centers may not have injection morphine. They will have only oral morphine. So in such cases, you have to give oral morphine trial. So if patient is not taking any opioids, then you can start with 5 milligram of morphine. And if the patient is on weak opioids like tramadol, you can start with 10 milligram morphine every 4 hourly. And you can adjust the dose every 24 to 36 hours. So we started this patient on 5 milligram of morphine 4 hourly and SOS. And he was having satisfactory pain relief for 2 weeks. But then he needed more SOS dose. You can see 4 SOS dose he was taking for the last 4 days. Now, do we need to do anything for this patient?
Sir, yes, sir. Dose escalation, increase the dose, adjuvant.
Yeah.
Many have answered increase the dose, sir.
Okay. So this patient is taking more SOS dose in addition to the regular dose. That means this patient requires more morphine. So you have to increase the dose of morphine. That's what we have to do. So how much we can increase, or what are the indication to increase the dose of morphine? If the patient is taking 2 or more than 2 SOS dose, PRN is same as SOS dose. Okay. then increase the dose by 30 to 50%. You can increase every 24 to 36 hours. Okay, so morphine will take about 24 to 36 hours to get the blood level stabilized. So this patient was taking 5 milligram. So if you increase, sorry, if you increase it by 50 percentage, that will be 7.5. Okay, but if somebody find it difficult to break the tablet into quarter, 4 pieces, then you can also increase it to 10 milligram. But it is always safer to use 7.5 milligram, because if the patient has more side effect, then they may not take morphine thereafter. So you can increase it up to 30 to 50 percentage every 24 to 36 hours. So I have told you, you can give SOS morphine in addition to regular morphine, regular doses. So suppose you are giving oral morphine, how frequently would you give SOS morphine? Anybody? Patient has taken morphine at 6 a.m. and patient says by 6:30 I have severe pain. He's approaching you. What will you do?
Sir, as a patient require as and when needed every 2 hours, not more than 2 SOS doses
Mhm.
till their pain is very safe.
Okay. Any other responses? Anybody else?
IV from oral. Change from IV from oral.
Mhm.
Give till there is pain relief.
Okay, we are talking about oral morphine. Okay. How frequently would you give SOS dose?
IV titration, again IV titration, use of adjuvants, second hourly.
Okay. Okay. Those who have already answered, can they tell why 2 hourly? Any response?
So onset of action takes at least 30 minutes.
Mm-hmm.
Peak of the drug.
Mm.
No other responses, sir. To avoid respiratory depression.
Okay. That's almost right. So we will see how frequently we can give SOS dose of morphine and why. So, so we have to understand a little bit of pharmacology about morphine. So this is Papaver somniferum or poppy plant from which you will get morphine. You can see these are poppy fields which are legally grown only in 3 states of India, that is UP, MP, and Rajasthan. And uh, uh, from which part you will extract morphine? Which part will give you morphine? Leaf, stem, flower, pod, root, which part?
Seeds, sir. Seeds.
Okay, and this is the lowest one, the white seed like thing is known as pod. Actually, morphine is available from all the parts of this plant, but um, there is something called the International Narcotic Control Bureau, which permits the countries to produce morphine from certain parts of the plant. So I think India is the only country which can produce morphine from the pod, and pod is the most abundant source of morphine. Okay, so the farmers make small cuts on the pod, and the sap which is coming out, they will collect it and dry out in the sunlight, and this will be exported to government opium and alkaloid factories, where it will be make from which they will make morphine powder. Okay, and then they will send it to corresponding pharmacies where morphine tablets are produced. Morphine is actually a weak base and it is hydrophilic also. So it is water soluble. Because of this nature, it has a slow onset of action and as well as longer duration of action. And you have to understand these facts because many people advise to put morphine sublingually or buccally or gingivally if the patient is unable to swallow. But these routes are not very much convincing routes, or from these routes morphine is not absorbed very well. If there is some action after administration through these routes, that means the patient, when they place morphine sublingually or buccally, have swallowed it, and that produces action. And you have to also understand that morphine has a bitter taste. So if you powder the morphine, then you have to sweeten it with some sugar or something, juice, etc. So what happens after absorption? So once you swallow, it goes into the GI tract and it is absorbed from the upper small bowel into the blood vessels. And from the blood vessel, it goes into the portal vein, and from portal vein to liver, where the metabolism takes place. And after metabolism, the metabolites are liberated into the systemic circulation. But some of the morphine bypasses the liver and reaches systemic circulation, but that amount is very less, maybe up to 10%. So the metabolism mainly happens in liver, but a minor part also occurs in GIT and kidney, but this is very minor. And 90% of morphine is converted into metabolites. That means 10% bypasses liver. And there are mainly two metabolites, morphine 3 glucuronide and morphine 6 glucuronide. And you can see the morphine 6 glucuronide is the component which will give you the pain relief, but it is formed in less quantity. So these are the major metabolites, but there are many other minor metabolites. So morphine 6 glucuronide, in short form M6G, is the active component which will give you the pain relief. So when you give orally, all this process has to take place. So um, as previously told, morphine will start acting by 30 minutes, but the peak effect will be by about an hour, 1 hour. So you have to administer morphine after 1 hour. But theoretically speaking, there is no limit for SOS dose. You can give it every hourly, but you have to also monitor the problems like sedation, um, myoclonus, delirium, etc. Otherwise, you can give it every hourly. There is no restriction to the SOS dose. So you can see our patients' morphine was increased, and now it is 10 milligram 4 hourly. But he says, I'm unable to take it every 4 hourly because I have more tablets. Why I should take 4 hourly? But if you are willing to give it less frequently, I am willing to take it. Do you have anything to tell to this patient?
Sustained release, twice daily tab.
Uh-huh. Okay. So sustained release morphine tablets are available, but I think as of now it is not available in India. It was previously available. I just inquired with people who are making sustained release, and they told now it is not available. But it is available across the world. So we have to understand the sustained release morphine tablet. The duration of action is 12 hours. So this patient was taking 10 milligram 4 hourly. That means 6 tablets every day. That is 60 milligram per 24 hour. So you can give 30 milligram BD morphine sustained release tablet. Okay. So this is costly also compared to the immediate release tablet. So these are the preparations of morphine available. In some centers, aqueous solutions or syrups are available. There are two types of tablets: immediate release and controlled release tablet. Immediate release tablet, which acts for 4 hours, whereas controlled release tablet for 12 hours. And injection morphine is also available. The strength will vary. So our patient is on 10 milligram morphine every 4 hourly for the past 6 months. But uh, when you were in taking casualty duty, this patient was brought to you with excessive drowsiness, and you ordered some blood investigation, and you found that patient has a serum creatinine of 5 milligrams per deciliter. Will you do anything with morphine dosage?
Reduce it,
Okay.
stop it,
Okay.
decrease to half,
Yeah.
stop it for a while.
Okay. Thank you. So, why do you want to reduce the dose of morphine? Anybody?
Because of the toxicity, the metabolites are circulating in the blood.
Yeah. Okay. Any more response?
Excessive drowsiness.
Okay. So let's see. So we have to understand that morphine is excreted from the blood by glomerular filtration. So in case of renal failure, what happens? Morphine 6 glucuronide accumulates, and the morphine and its metabolite will be there in the system. So morphine half-life is prolonged. So it is not excreted from the body, and it is there in the body. So you have to actually, as somebody told, you can reduce the stop the morphine maybe for 1 or 2 doses, or maybe up to a day. And once the drowsiness is over, then you can restart the morphine with a reduced dose. So increasing the spacing. So instead of 4 hourly, maybe you can give it maybe 8 hourly or 12 hourly or even once daily, and reducing the dose is also has to be done. And another choice is you have to switch over to other opioids which are renally safe opioids like methadone or fentanyl. So you have to understand morphine is excreted by kidney. So in case of renal failure,
Treatment
you
for
have
drowsiness.
sorry.
Dr. Radha, can you unmute? Yes, Dr. Radha. Dr. Radha, were you about to ask something?
Because we are, how to treat the drowsiness? Will it
Okay.
pass it off on its own?
Suppose you stop morphine for some time. Maybe if you skip 1 or 2 doses, the morphine drowsiness will be over by its own. You need not do anything usually.
Okay. Thank you.
So our patient had renal failure, and because of that, we reduced the dosage to 5 milligram 8 hourly. After 2 months, he was unable to swallow anything, including morphine. So what are the options now for pain relief? He's unable to take anything orally, but he has severe pain if he is not taken morphine. What will you do?
Sir, patch, fentanyl patch, rectal route, IV morphine, transdermal patch, buprenorphine, fentanyl, methadone is renal failure. Subcutaneous.
Okay. So suppose this patient is at home, all those routes, what you have told, transdermal, fentanyl, or injection morphine, subcutaneous morphine, all are possible. But suppose this patient is at his home and he is not at the hospital. What are you going to do? Suppose they are poor also.
Rectal route, sir.
Okay. So that's correct answer. So we have to understand what are the routes through which we can administer morphine. So intravenous or subcutaneous route. Oral route is the most common route, followed by intravenous or subcutaneous route, then parectal route. So morphine can be administered parectally, epidural, intrathecal. So these are the routes through which you can administer morphine. And so you can administer same dose of morphine. So this patient was taking 5 milligram 8 hourly. So you can administer 5 milligram parectally 8 hourly. So there are various recommendations in various literature. So some advices regarding use the same fast acting tablet. And as I told you previously, it is hydrophilic. So you can make a paste of morphine tablet. Place the morphine tablet in the hand, put 2 drops of water. You can make it a paste and rub it over the rectal mucosa. So that will give the same pain relief. So oral route is comparable to parectal route. So this is what we can do easily for patients who are unable to swallow morphine. But this may not be acceptable for some patients. So we will move on to another patient. So we are leaving Mr. X. Now our another patient, Mrs. K. 55-year-old lady with carcinoma of the colon, has abdominal pain, continuous, on 10 milligram of morphine 4 hourly.
Dr. Sunil, can you speak a little louder, sir?
Okay, so patient is on 10 milligram morphine 4 hourly, and her pain is stabilized. So when they saw a doctor, they told him, they told the patient to replace the morphine with the fentanyl patch. 25 microgram patch was applied. But the next day, patient came to the doctor and told him, doctor, I didn't had pain relief with fentanyl. So I removed the fentanyl patch. So doctor asked what happened. So because of pain relief, there is no pain relief. I removed the patch after 5 hours. So what will be your answer to this patient?
It takes time to take effect.
Okay. Anybody
Should
else?
wait. Fentanyl patch takes 12 hours. It takes time.
Yeah. So that's what we have to understand. So fentanyl is available in available as injections, transdermal patch, and available as a lollipop, that is oral transmucosal fentanyl citrate. Compared to morphine, fentanyl is lipophilic and it is more potent than morphine. So it is 100 times more potent than morphine. Fentanyl is 100 times more potent. So what happens if you apply fentanyl patch? Uh, it forms a subcutaneous tissue depot. So before release into the bloodstream, it produces a subcutaneous tissue depot. And after 8 to 12 hours, fentanyl is liberated into the circulation. So suppose you have applied 25 microgram patch. That means 25 microgram of fentanyl is liberated every hourly. So that's what the strength of the fentanyl patch indicates. And the duration of action is for, so once applied, it will act for 3 days. But you have to understand that you should not shave the area, because abrasions on the skin and temperature also affects the absorption of the fentanyl. But another important thing is when fentanyl is indicated, if the patient's pain is stabilized. That means when the patient has pain and there are many ups and downs, sometimes pain score is 10, and after an hour it comes to 2, and it is frequently changing over a day. That means patient's pain is not stabilized. In such patients, fentanyl should not be used. In such patients, we have to stabilize the pain with morphine and find out how much dose of morphine is necessary. And then once the patient has, we found out that the dose of morphine is stable, that means patient doesn't require much SOS dose, then you can convert it into fentanyl patch. But you have to understand the cost of fentanyl patches, it is costlier than morphine. Okay. So this is another patient, Mr. H, 70-year-old man with a carcinoma of the lung, has neuropathic pain of right upper limb due to nerve infiltration. He is on morphine 10 milligram 4 hourly, amitriptyline 75 milligram HS, and pregabalin 150 milligram BD. So his main problems are delirium, myoclonus, and patient doesn't have proper pain relief. So how will you manage this patient? Patient has neuropathic pain on morphine, amitriptyline, and pregabalin. So amitriptyline, I think it is almost good dose. Even pregabalin, he is taking good dose. So how will you manage this patient?
Sir, stellate ganglion block,
Okay.
clonazepam,
Hmm.
steroids, sir.
Okay.
Reduce morphine, midazolam.
Hmm. Okay. So why this patient developed delirium and myoclonus? Any comments?
Due to excess morphine,
Yeah.
renal failure, overdose morphine, serotonin syndrome.
Okay. Okay. Yeah. So we will think of the most common situation. Either the it means a patient has more morphine in the body. So it may be because the pain is not responsive to morphine, or it may be due to renal failure. But suppose this patient has pain is not morphine responsive. That's why he developed delirium and myoclonus. What are you going to do?
Opioid rotation,
Opioid rotation. Okay. So what are you going to do for opioid rotation?
change to other opioid switching, withhold morphine,
Mm.
low dose ketamine,
Okay. So why ketamine?
and NMDA blockade.
Yeah. Okay. Thank you. Thank you for your suggestions. And I would say that this patient is a suitable candidate for starting with methadone. Okay. Uh, so just see what are the properties of methadone. So methadone is a combination of two isomers, S-methadone and R-methadone. And you can see it acts on all the receptors, mu, kappa, and delta opioid receptors as agonist, whereas morphine acts only on mu receptor as an agonist. But you can also see that it acts as an NMDA antagonist. So ketamine is an NMDA antagonist. Methadone is also one NMDA antagonist. And you can also see that methadone also acts like a tricyclic antidepressant. So like amitriptyline or imipramine, it also inhibits the reuptake of noradrenaline and serotonin. So these are the properties which makes methadone a good medication for treating neuropathic pain. But there is one side effect. You can see it blocks human either a go-go related gene, which are abundantly present in myocardium. And what happens if that is blocked? It increases the QT interval, and it can produce torsade points and can cause sudden death. So this is this is one of the serious side effect. But we have to understand that most of the studies on methadone were conducted in patients who are on opioid substitution therapy, and they are taking hundreds of milligrams of methadone, where QT interval prolongation and dose points are possible. But the doses which we require for pain relief is less than 50 milligram. And there is a study conducted by MD Anderson Cancer Center where they have treated, I think, about 50 patients with less than 50 milligram of methadone per day. And they didn't find much prolongation of QT interval. So if you use it properly for selected patients, methadone is a good medication or good analgesic. Okay, so this is another important thing which we have to understand about methadone. You can see that after administration, methadone will be seen in blood for 2 to 4 hours, but after that it will go into the tissue binding sites. And once these tissue binding sites are filled, then only it is liberated into the systemic circulation. So this will take about 5 to 7 days. So, unlike morphine, methadone should not be increased every 1 or 2 days. You have to wait for about 5 to 7 days. So, till that time, you have to continue the previous opioid on an SOS basis. Okay.
So we have a question. What
Yeah.
about pethidine?
What about
Pethidine.
pethidine? Okay. Pethidine doesn't have much role in chronic pain because it is available only as injection, and it has seen that the metabolite norpethidine, it accumulates even in patients with normal renal function. So it is not usually used in chronic pain treatment. And methadone is safe renally because the main excretion is by bowel. So there is a you can go through this paper. This is published in 2019. Safe and appropriate use of methadone in hospice and palliative care. Expert consensus white paper. So this is a very good paper to get more about methadone. But there is a methadone supplement which came in Indian Journal of Palliative Care in 2018. Um, it was specifically on methadone, written by Indian authors. So it will be useful if somebody want to use methadone. So this is the flow chart which we use for methadone in our home care unit. So most important thing is the patient should have a reliable caregiver. Then only you start methadone, because if the dose of methadone is increased, then it will lead to severe problems. So that's why a reliable caregiver should be there. And if there is reliable caregiver, then you will ask for history of sudden unexplained death in family, because Torsade points may present as sudden death and congenital prolonged QT syndrome. If yes, you will not start methadone unless the patient is in end of life. And if there is no such history, then you will start straight away on methadone. If the patient is taking less than 60 milligram of oral morphine per day, you can start with a 2 to 7.5 milligram per day. And 60 to 199 milligram, then, and if the patient is less than 65 years, the conversion is 10 is to 1. Suppose patient is taking 100 milligram per day oral morphine, then 100 divided by 10, that is 10 milligram of methadone per day. So you can give 5 milligram BD. So you can read that paper and you will get more information, or even I will it will be here in my presentation. So in opioid naive patients, usually methadone should not be started if you are not experienced. And same dose for opioid naive as well as if the patient is taking less than 60 milligram of oral morphine. 2 to 7.5 milligram can be used. And if the patient is already on opioid, which we have already told. Okay, so in case of methadone, what we have to understand is methadone has many drug interactions, and many drugs or medicines which we use in palliative care has interactions, and it can either decrease or increase the dose of methadone. And we have to be careful about opioid equivalent dose. Uh, you have to convert it properly. And most important thing is you should not increase the dose of methadone till 5 to 7 days. And this is the methadone which is available in India. Only one pharmaceutical company methadone in India, that is Rusan. So it is available as syrup as well as tablet. It is RMeth. Okay. Now we will leave methadone and we'll move on to some other aspects. So this is a 70-year-old man with carcinoma of the lung and is complaining of throbbing pain on right front of chest, continuous pain, and pain score is 5/10. He is a non-epileptic and is on phenytoin 100 milligram ED. How will you manage his pain? This patient has a moderate pain. So as per WHO analgesic ladder, you have to select which step of the ladder.
Step 2, sir.
Okay, step 2. So how will you manage his pain?
Avoid tramadol.
Okay. Then what can be given?
Change phenytoin to valproate,
Mm,
codeine,
mm,
tapentadol,
mm,
morphine.
mm. Okay, those are options. Why tramadol should not be used? Tramadol reduces the seizure threshold. So this patient is already an epileptic. So there is a chance that with tramadol you can precipitate a seizure. So that's why tramadol is avoided. But if there is no way, you can give tramadol, but don't give intravenous push if you are giving IV very slowly. So codeine, low dose morphine, or now another opioid, dextropropoxyphene, has came back, which was banned in 2018, I think. But now the Drug Controller General of India has approved to use dextropropoxyphene in cancer pain management. So dextropropoxyphene can also be used. It usually comes as um, a combination of 65 milligram dextropropoxyphene plus 325 milligram of paracetamol, and it is available as plain dextropropoxyphene also 65 milligram. Okay, we will move on to another patient, Mrs. P, on tab morphine 50 milligram Q4H. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage this patient? Your comments, please. Patient is on 50 milligram of morphine 4 hourly, and she complains of severe pain.
Sir, can you put your headphone closer to you?
Okay. So you have injection pentazocine and oral morphine. So how will you manage?
Sir, give pentazocine IV,
Okay.
morphine.
Mm.
Yes. Extra dose of morphine, pentazocine as an answer.
Okay. Thank you for your response. Let's see what can be done for this patient. So before moving on to the answer as such, we will do some background analysis. So what are opioids? For a medication to become opioids, it should have two properties. One is that it should act by combining with opioid receptors. And Second thing is its action should be antagonized by naloxone. These are the two properties for a drug to become opioid. And there are actually four receptors for opioids: mu, kappa, delta, and opioid receptor like one, OPRL1. So that's another receptor. Previously sigma was considered as an opioid receptor, but now it is confirmed that it is not an opioid receptor. Okay, so it is seen throughout the nervous system, and based on the action on receptors, it is opioids can be divided into three. This is important from a clinical point of view. Agonist, antagonist, and agonist, antagonist. So what are agonist? So you can see agonists are medications which combines with opioid receptors to produce physiological activity. So the physiological activity is pain relief. And this is something which you have to understand about agonist. So you can see an agonist, this is the dose. Suppose morphine is an agonist, so you will give 5 milligram of morphine and you will give this much pain relief. And when you increase the dose of morphine, you will get corresponding pain relief. And when you give up to this, so this much dosage, you will get complete pain relief. So if the patient has completely opioid responsive pain, you will get 100% pain relief. So this means there is no ceiling effect for analgesia. So agonist drugs have no ceiling effect for analgesia. So all the commonly available opioids are agonist: morphine, codeine, methadone, fentanyl, tramadol, etc. are agonist. But what is an antagonist? So the two examples are naloxone and naltrexone. So these drugs have action only when um, only in presence of an agonist. So if you have taken um, a morphine and if you are given naltrexone, then the actions of morphine will be reversed. But if you are opioid naive, you have not taken any opioid, and if you are given naltrexone, there will not be any action. What about agonist and agonist? There are two agonist and agonist which we usually use. One is pentazocine and the other one is buprenorphine. So just compare these two graphs. The left one is for agonist and the right one is for agonist and agonist. You can see in case of agonist and agonist, when you increase the dose of agonist and agonist, there is a point till which you will get pain relief. You can see until this point you will get corresponding pain relief. But after that, even if you increase the dose, the curve plateaus. That means agonist and agonist opioids have ceiling effect for analgesia. Okay, so this is the main difference between the two groups. So pentazocine is an agonist and agonist. So it has agonist effect at kappa receptors, whereas weak antagonist at mu receptor. So what happens if you give pentazocine to a patient who is on morphine? Our patient was taking 50 milligram of morphine 4 hourly. So what happens? Pentazocine will displace morphine from the mu receptor. So now the pain relief is due to pentazocine, which is acting on the kappa receptor. So the opioids which acts on mu receptor are the potent analgesics. So now even if you with good intention you have given pentazocine, you have actually exacerbated the pain. So that's what happens if you give pentazocine to this patient. So you have to take history, as somebody told, did she miss any dose of morphine, and ask to take tab morphine 50 milligram, and if she has taken more SOS dose, we have to increase the dose of morphine. That's what you have to do. So we will move on to adverse effects of the opioids. So what are the adverse effects of opioids? We can divide it into two. One is side effect and the other is toxic effects. So what are the side effects? These are the adverse effects with normal therapeutic doses. So can somebody says what are the adverse effects? Oh, sorry, side effects.
Constipation, drowsiness, itching.
Okay, thank you. So those are common side effects: constipation, nausea and vomiting, sleepiness and tiredness. These are the most common side effects, followed by itching, dry mouth, and urinary hesitancy, which are minor side effects. And constipation, it occurs in almost 95% of patients, and it will be there as long as the patient is on opioid. So you have to use regular stimulant laxatives along with opioids. When you write opioid, you should also write stimulant laxative. So I am underlining the stimulant laxative like bisacodyl, senna, sodium picosulfate, etc. You should not give the methyl cellulose or things like that. That is bulk forming laxatives. It is usually it is contraindicated in opioid induced constipation. Nausea and vomiting, and it occurs in about 30% of patients, but for the first few days only, maybe 3 to 5 days, and after that it will resolve by itself. So for the first 3 to 5 days you can give antiemetics which acts on chemoreceptor triggers on. So the most abundant receptors on chemoreceptor triggers on are dopaminergic type 2 receptors. So this D2 can be blocked by haloperidol, which is the strongest D2 blocker, followed by metoclopramide or domperidone. And other receptors in CTZ are 5-HT3 receptors. So you can use ondansetron, organisetron, etc. But haloperidol, usually many people use D2 receptor blockers. So sleepiness and tiredness is again self-limiting. It will be there for 3 to 5 days. Thereafter, it will be over. And toxic effects. So we were talking about side effects. These are toxic effects. So toxic effects are adverse effects when administered dose is higher than the required dose, or when the patient has poor response, poor opioid responsiveness, or when the patient develops renal failure. So these are the symptoms and signs are delirium, myoclonus, drowsiness, and pinpoint pupil. This means suppose a patient is on opioid morphine and they develop this delirium, myoclonus, or drowsiness. That means the patient is taking more than the required dose. You have to stop it for some time, maybe skip 1 or 2 doses and then restart with less dose. So this was something which somebody talked about at first. Opioids producing respiratory depression. This is a common concern, but let's see what are the evidence. So this is something which came way back in 2003, and it says patients usually takes their medications by mouth, and combined with the normal gradual increase in dose ensures that respiratory depression is unusual. So this is a systematic review, and it continues to say that when respiratory compromise does occur, you should seek an alternative explanation such as pneumonia, pulmonary embolism, or cardiomyopathy, or co-administration with another sedating medication such as benzodiazepine. So another thing you have to understand is pain is the physiological antagonist to respiratory depression. So usually, actually, I have been in palliative care for more than 15 years, and I haven't seen any case of respiratory depression. I have given injection morphine maybe more than thousands of patients, and oral morphine for many patients. I haven't seen come across any such serious respiratory depression. So this is another important concern, opioid causing addiction. So we have to understand that there are two things. One is physical dependence and the other one is psychological dependence. So psychological dependence is known as addiction, whereas physical dependence is manifested as withdrawal reaction. So what is addiction? So you can see this is the definition by American Society of Addiction Medicine. It is considered as a disease with a genetic predisposition. with psychosocial and environmental factors influencing its development and manifestations. So if you have a gene, you will be susceptible for addiction. And if environment is also favorable, like you are working in an OT and your friend is taking this for some other purpose, then there is a possibility that you may also become psychologically dependent. So this is a, you have to consider it as a disease. And the manifestations are, the patient would take this medicine at any cost. He knows that it will cause harm to him, but still he will use it. So as I told you previously, physical dependence will be manifested as withdrawal syndrome. Usually lacrimation, yawning, stomach ache, diarrhea, etc. And this is pharmacoeconomic something which you have to be very careful, because you will be giving writing medications, and maybe after a few days patients will come and tell you, I don't have symptom control, I don't have pain relief. Then suppose you have written fentanyl patch, the patient is very poor, he is unable to afford it, he may not actually use it. So we have to understand the cost approximately. So uh, uh, you can see 5 milligram of in 4 hourly, total 30 milligram, 3 tablets will cost only 3 rupees 50 paise. And the corresponding doses of tramadol and fentanyl patch, you can see tramadol will, sorry, fentanyl patch about 250 to 400 rupees for 3 days. Methadone is almost comparable to morphine. Tramadol is also costly compared to morphine. So this is short about step 3 opioids. I'm happy to take any questions.
So there are a couple of questions which is unanswered here. So how do you distinguish whether drowsiness is side effect or a complication?
Okay. What do you mean by complication?
Dr. Avnish, can you unmute and speak?
Yes,
City?
sir. I mean, how to say, how to distinguish whether it is a side effect or a toxic effect.
Okay. When you start patient on the first patient on opioids for the first few days, sleepiness will be there. But if the patient has toxicity, he will be severely drowsy. Along with that, there will be delirium or myoclonus. So you will not be able to wake up the patient. And when you, even if you wake up, the patient will be awake for a second and then will immediately go to sleep. But if it is side effect, when you call the patient, usually they will wake up and they will start talking. But in the other case, toxicity, it will not be there.
So Dr. Avnish have also asked whether methadone has a separate form or something.
Dr. Avnish, are you asking about narcotic drug chart, or can you ask?
Yes, a narcotic prescription form, I think 8A is
Yeah,
for
yeah,
fentanyl.
I understand. Okay, it is the same thing which we use for morphine tablet. So
Okay, thank you, sir.
in India now the NDPS Act, it is actually controlled by the central government. Previously, it was by state governments. Now the law is common across the country, so it is uniform. So if you have RMI license, that is recognized medical institution status, you can stock ENDs. ENDs means essential narcotic drugs. You can stock and dispense. So this includes 6 medications: codeine, hydrocodone, oxycodone, morphine, fentanyl, and methadone. But oxycodone and hydrocodone is not available in India. Others are available.
So Dr. Sudha have asked about the dosage of syrup methadone.
Okay, syrup methadone, 1 ml contains 5 milligram. So when you convert from morphine, you have to select the dose, but 1 ml contains 5 milligram. There is no difference between tablet and syrup. The only thing is you have to be very careful with syrup, because if you advise the caregiver to take methadone syrup instead of suppose you have asked 1 milligram to be given at night, and you have asked 1 ml to be given after diluting it with 4 ml of normal saline. But sometimes the caregiver may take 1 ml directly from the syrup and may administer. So you have to be very careful with syrup.
Is there any more questions to be answered?
Anybody else? Okay, fentanyl patch. Fentanyl patch, various strengths are available. We have 12.5, 25, 50 microgram with us, but I think 75 microgram is also available. If you have any comments, you can, from your experience, you can also speak. I would like to give one of my experience, because this is something which all of you should be aware. There was a patient was brought to us from one of our acquaintance, um, telling that this patient consumed 50 milligram tablet morphine. Actually, this patient was a roommate of another person who was suffering from carcinoma of the lung, and he was actually prescribed 50 milligram of morphine. The nurse actually uh, by mistake gave it to the other patient who was not having malignancy. So everybody was scared. uh, but I want to say, even we were also scared. Probably we'll go into respiratory depression and things like that, but there was nothing. The patient even didn't had drowsiness. Okay, all the PowerPoints will be sent to you by Rajalakshmi. You will get all the PowerPoints which was used by the faculty. Yeah, Dr. Geeta is asking what is the maximum dose of morphine. Yeah, this is a usual question. Can somebody answer this?
Not more than 400 milligram per day.
Okay, okay. Thank you. Theoretically, there is no maximum dose for morphine, and I want to say that when we didn't had methadone, we had a patient who was on 400 milligram of 450 milligram of morphine 4 hourly, and I know that in Kerala one of the patient was using 750 milligram 4 hourly. So theoretically, there is no maximum dose of morphine. The dose which is required for the patient is the dose that's the maximum required for that patient. So we cannot say there is maximum dose. Okay, are there any alarming symptoms that we should look for on for 100 dose? No, Dr. Ashish, when you titrate morphine, you will be monitoring for the toxic effects. Suppose the patient is on 5 milligram morphine, you will be, there is no pain relief. You will switch over to 10 milligram of morphine. But whenever you increase the dose of morphine or whenever the patient come for review, you will ask for delirium, myoclonus and drowsiness, and if there is these symptoms, that means you should not increase the dose of morphine, and sometime you have to reduce it if it is really troublesome for the patient. Yeah, for pediatric patient also there is no maximum dose. Conditions per antagonist. Okay, so I haven't used antagonist even though we have stopped naltrexone, naloxone, sorry. When the respiratory rate is less than 8, that's an indication to start naloxone. I haven't come across such a situation. So what I understand is if you titrate it carefully, looking at toxic symptoms, then usually it will not happen. But I know there are many anesthesiologists who has seen respiratory depression, because if something goes wrong, it is easier for them to manage. Rajlakshmi, can we move on to the patient story? I think if you have doubts, you can, yeah, naloxone dose to be used to treat toxicity. Okay, so there are various regimes. Maybe some people advise 10 microgram stat followed by 10 microgram every 2-3 minutes till the respiratory depression is or his picked up, respiratory rate is picked up. But some people also advise us about continuous infusion. But we have to also understand that if you completely reverse it, then the patient will have severe pain. Okay. How often have you seen myoclonus as a toxic effect? Yeah, that's not uncommon. That's what I want to say. Maybe 10 to 20% of patients. Rajlakshmi?
Sure, sir. Dr. Gautam?
Madam, I'll share it from my screen.
Sure, sir. Sure, sir.
Uh, is it visible, madam?
Yes, sir. You can make it into a presentation view.
Yeah. Slideshow.
Yes, sir.
So, good evening, everyone. Now I'm going to talk about a patient who is 76-year-old female. She was diagnosed to have small cell carcinoma of lung. She had spinal and bony metastasis, and she had a pathological fracture of the right neck of femur. And she underwent right hemiarthroplasty. She's a 76-year-old female presented to us with severe back pain with right hip pain and reduced range of movement since 15 days. She was apparently normal till June 15th of 2020. She had the history was she had a very trivial tip while walking inside her home, from which she developed hip pain and backache. She was in a denial to go to any nearby hospital and treated herself to have a sprain and taking self-treatment with oil application and hot water applications. Even we advise, and she was not in a position to go. She was denying to go to hospital. But gradually, the pain became more severe and she was not able to lie flat on back. And she was not able to walk, and hence she came for a medical help. On examination, she was conscious oriented. She is not pallor, ectric, no clubbing, no bilateral pitting fetal enema. Her heart rate was 112. Blood pressure was 140/80. She was afebrile, and her VAS score was 10 out of 10. Local examination of the right lower limb. Patient lying in left lateral position because she is not. Her right hip is tenderness is present on right hip, and it is radiating. The pain is radiating up to the leg, and limb length discrepancy was present. Her distal pulses were felt, and there was no distal neurovascular deficit. Patient was not allowing to make her lie down on her back. So we did, of course, we did all blood investigations. That was normal, but this was the thing. HRCT showed why we did HRCT, because to rule out COVID. Because till now we don't know that she had malignancy. We thought she wanted to undergo a hip surgery, and we wanted to do a HRCT. There, a small, well-defined speculated mass lesion in the right lower lobe, focal lytic areas involving few vertebrae to rule out metastasis. This was the report. And CT scan of bilateral femur and pelvis. It showed focally minimally invasive lytic lesion. It's involving right femur and femoral shaft, and there was comminuted fracture of the femoral neck associated with minimal soft tissue mass. It was a pathological fracture. The problem, the issue is she is my mother's auntie, and she is from a small town in southern part of Tamil Nadu. And till this point, her family was not aware of the metastatic disease. The parent's grandson is a pediatric oncologist himself, and so he was, with his help, I was able to explain the further management and possible outcomes. But at this point, her only concern was very severe hip pain, and she was not able to walk. In her hometown, all the clinics were shut down due to pandemic, and there was no real medical help. Hence, she traveled all over 250 kilometers to our hospital. And further management, initially, she was given a nerve block for immediate pain relief. After a complete evaluation and for improving her daily activities of living, weighing risk versus benefit ratio, she underwent right hemiarthroplasty. We had so much of discussions with the orthopedician whether she will be able to withstand. Even there was no, as the fracture was so comminuted, we didn't have any other options of surgery rather than to go in for a right hip hemiarthroplasty. And she got, and post-operatively she got relieved of pain, and she gradually walked with support after 20 days of complete bed rest, because she had many bones metastasis also. And she was discharged to her home. She went back to her home, to the small village, after 25 days of admission. Till now the story was not over, but after 1 month her disease progressed. Now, again, no one is willing to treat her, as she is having, and she is having burning sensation all over the body. This time I made her, and this time she was not willing to come to the hospital. Then I told, as she is a distant relative of me. I told, nearby there was an apartment. I told, I won't admit in the hospital. I'll take care by admitting in an apartment. This time I made her comfort by admitting in a nearby apartment. She was not willing to get admitted to the hospital again. She was not getting relieved of pain, and she was not able to sleep, and she developed prognathism, and she is not able to chew and eat, and she was not willing for a nasogastric tube feeding also. Before coming to here, in Madurai, she underwent a PET scan. PET scan report was the following: she was metabolically active, irregular soft tissue mass in the right lower lobe of the lung. It was a metastatic mass. Ipsilateral and contralateral mediastinal lymph nodes metastasis was noted. Extensive osseous metastasis as described, and there was in almost all the bones, even in the jaw, even in the mandible, everywhere. Probably, I don't know, because of this only the prognathism she developed. Before a month, she was okay. She was having everything orally. Within a month of time, she developed a prognathism. And she had liver, left adrenal, and right renal metastasis were noted. Left cerebellar metastasis was noted. And she was on the following medications. She was on Geftinib OD, and she was on tablet Dolo 650 milligram thrice daily. I gave diclofenac IBOD and fentanyl patch 25 microgram hourly. Fentanyl patch I just stuck, and morphine 10 milligram. I told it is. I gave it actually sixth hourly. I'm sorry, fourth hourly. I gave QID. I'm sorry, I gave fourth hourly, and with in consultation with a nearby oncologist, I because she was not getting relief of the pain, we gave steroids, methylprednisolone 1 gram loading dose, followed by methylprednisolone 5 milligram IVOD daily. And she had constipations also, so we gave Dufelac 10 ml in the night. The patient's main concern was that she is deteriorating, and family members did not leave me to reveal to the patient herself that she is having cancer, because she was from a small village. When we tell she is having cancer, they told she will become depressed and she won't listen to anyone. Her daily activities were reducing, and she is not able to tolerate the pain in spite of all these analgesics. Because of pain, she was having insomnia, and even benzodiazepine administered, she was moaning throughout the night. As her daughters and son-in-law were not having any financial issue, their major concern was to make her comfortable and have a peaceful death. We don't have a dedicated palliative care physician in our place. Even to my knowledge, before joining this course, palliative care means administering painkiller and calming patients. This was the idea I had even before I was joining in this course. These were all the main concerns for me. To summarize, she is a 76-year-old patient with CA lung with spine and skeletal metastasis and had a pathological fracture of right hip, for which she was operated and was fine for 1 month after operation. After 1.5 months, she deteriorated and having uncontrollable burning sensation and pain all over the body, not responding to the maximum dose of analgesics. So I know this is something to do with the management of pain, but these were all the things I wanted to ask to my senior and fellow colleagues. Even if the family members are not allowing to reveal the cancer to the patient self, is it okay to explain the patient regarding her disease? Sir?
Okay, you can read out all the questions.
Okay, sir. Okay. And how exactly to deal when the patient is not able to eat and not willing for any further interventions like nasogastric tube insertions. Patient herself, though she is not getting a proper treatment in her hometown, she wants to get back to her hometown and have a peaceful ending. And family members are willing to take her back. Where and of course there is no medical help there. Even they can't take morphine tablets there, sir, because it's a very small town. So from a physician point of view, whether we will allow her to go back her home with this suffering, in spite of giving all this necessary option, they wanted to take her back home with the suffering, and there is no medical help. How to approach this problem?
Thank you, Dr. Avnish, for taking care of this lady. So, Avnish, can you come on to? We will discuss this. Can you come on to the medication chart first?
Yes, sir. Geftinib body, sir.
Yeah.
And Dolo 650 thrice daily. Diclofenac OD I gave, sir, because her creatinine was also on a, it was borderline. I don't want to mess up this thing, but I don't know. I didn't have any other options other than this thing. And I had fentanyl. I stuck up a fentanyl patch and morphine. I wrongly addressed the QID. I gave fourth hourly. and methylprednisolone 1 gram IV loading dose followed by 500 milligram IV OD daily. And she had Dufilux, sir. And night in between, I gave diazepam IM or midazolam IV I gave for the night to calm her.
Okay. Can you describe about pain uh, um, all over the body,
Sir,
severe pain plus
that's
burning?
what, sir. It was it was a typical allowed. Only after the joining this course, I'm able to. Sir, this auntie, she's my grandma in the such.
Oh,
She's no
oh,
more. She had a peaceful ending on middle of the September.
okay,
After
okay.
this, only this course started. Now I am able to realize she was not even allowing me to touch her. But she is at the mercy of me because whenever I just enter the room, she tells Gautam and you just save me, make me relieve of the room because she doesn't know that she is having cancer. But
Okay.
she is not allowing me to touch also. Even if I touch, it was so painful. I think that is allowed in sir. Wherever I touch, especially
Yeah.
in the thighs, she had severe thighs, both the thighs. She had severe allodynia. In the hand and all, it was okay, sir. But all over the trunk, she was having burning sensation. The
Yeah.
chest, the abdomen, and in the legs, she had severe allodynia. Even if I touch, she told it is severely paining. It was a simple touch, it was severely paining.
Okay. So
She is not allowing her to, she is not allowing us to turn sideways because even if we touch, she is having severe pain. And with so much of with talking with her because we need to clean her up, we have to see whether she is developing that source everything. We gave almost maximum care we gave, but
yeah.
this pain because we don't have dedicated palliative care people in our place. I wanted to do it because there are many people like this in our place. There are many people in the we thought everyone will tell, okay, we are giving morphine. The patient is simply telling that she is having pain. Morphine is the highest dose. What else we can give? The physician in themselves they tell like that. They are receiving morphine. What else you want me to give? You are an anesthetist by yourself. How will you kill the pain even when you are doing the morphine? Morphine is the highest analgesic. What else you want me to do? They asked me like that, sir, initially. I don't know what to answer. So this was her pain. Everywhere she was having allodynia.
Okay.
And I wanted to make her comfortable, but it was in vain. I was not able to do that.
Okay. So uh, uh, I think I suggest some changes in this prescription. As you told, if she had renal failure, even I would avoid diclofenac, all the NSAIDs. And paracetamol maybe given 4 to 6 hourly. So the duration of action is 4 to 6 hourly. So at least give it 4 times daily. And Dr. Archana was saying about amitriptyline. So maybe we can try with amitriptyline, start with 25 milligram and gradually increase it up to 75 to 100 milligram. Um, and I see that morphine and fentanyl. So uh, maybe the dose of morphine increase and stop fentanyl, or increase the dose of fentanyl and stop morphine. Both are possible. If she is on fentanyl and if she require SOS dose, you may I think she needs morphine increase rather than fentanyl patch, because as you told, she has uncontrolled pain. So you can titrate morphine and see whether her pain responds to morphine, because all the even neuropathic pain are partially sensitive to opioids, and sometimes she might have pain relief when you titrate morphine. And methylprednisolone, yeah, usually steroids and NSAIDs, as far as possible, avoid it because it will increase the GI toxicity. But if you think it is definitely needed, then okay, you should go with that, with gastro protection. And as I told previously, opioid induced constipation, if we understand the mechanism of constipation, we have to add stimulant laxative, and difalic is lactulose, which is a osmotic laxative. So if she was passing motion on that, it should be okay. But when you start opioids, it is always better to start on stimulant laxative like bisacodyl, senna, or sodium picosulfate. So I think another option would have been methadone, but I think it was not available to you.
Yes, sir. It was not available. The steroid also, but initially, first 2 days she was responding to steroids, sir. She was comfortable because the second day that her VAS score was down to 5 when I started steroid. But again, she became resistant to steroid also. After third or fourth day, she became resistant to steroid. Again, she was back to square one with severe pain, burning sensation, everything, sir. Because the available oncologist here, they told when you are when even with good dose of morphine, when you are not able to do, you can try steroids. Sir, I have seen, I wanted to try fentanyl, I'm sorry, ketamine as such, but she was not in a hospital thing. And of course, their daughters and son-in-law, everyone, they accepted that she will not survive. They wanted just a, comfortable, peaceful death. That was a open. That was an open statement by their daughters and son-in-law. Uh, but as an anesthetist, I was very afraid to use ketamine in a home-based care because suddenly if she develops a delirium, I know she won't with this thing develop. We can't tell no. Suddenly she develops delirium in her home. She started scream. Already she is moaning throughout the night because of ketamine. If she starts delirium, ketamine-induced delirium, it will be very difficult for me to manage in home-based care. So I was not in a position to use ketamine. Of course, many of our colleagues, they told lidocaine infusion probably next time whenever um, next time whenever I try this patients, I will probably try IV lidocaine, sir.
Okay, Dr. Avanish was talking about ketamine infusion, but I want to say that we administer ketamine subcutaneously, IV, and even orally. The same injection can be administered orally. It is bitter, but you have to sweeten it with some fruit juice or something, and you can administer orally. So subanesthetic doses of ketamine is actually useful, and after oral absorption, ketamine is converted into norketamine, which is better analgesic also. So we usually give ketamine orally if needed, if we suspect some central sensitization.
So regarding the discussion parts.
Yeah, please come on to that. Yeah, ketamine start with low dose, maybe as low as 10 milligram TID, and then gradually titrate up. Okay, even if family members are not allowing to reveal the cancer to the patient itself, is it okay to explain the patient regarding her disease? Okay, so here the family members knows about the prognosis and diagnosis of the patient, but they don't want to reveal it to the patient. So is it okay to explain to the patient regarding the same? Anybody can answer this. I have seen some comments in the chat.
In my opinion, we should explain this to the patient, because as a patient, it is actually her right to know about her disease and her treatment options. Even if you look at a patient right, that's what it says.
Yeah, thank you, Dr. Abir. So, Dr. Gautam, we have a detailed session on communicating bad news as well as how to manage this situation. But for now, I should say, as Dr. Abir said, patient has the right to know about the disease. Okay, but this also includes some ethical principles also here, because patient has the autonomy. That's why we say that patient has the right to know. But the ethical principles, these are mainly talked about in Western countries like UK, USA, etc. And there, the doctors has to speak to the patient directly, not to anybody else. If the doctors speak to anybody else regarding the diagnosis or prognosis to somebody else, actually the patient can sue the doctor. But we have to look the culture here, where the patient is accompanied by the family members, and the family members will be there throughout the course of illness. They will be taking the patient to wherever she go. So we have to also respect the autonomy of the family also. So what happens if you break the news against the wish of the family? The patient will be taken away by the family, so that you will lose a chance to help the patient. So what we do is, we will talk to the family regarding the importance of communicating the bad news. So there is a way to talk to the family, what all aspects you have to cover, etc. This will be covered in management of collusion. And then with the help of the family, you have to actually come to the side of the family. Why they are telling you should not tell it to the patient? Because they love their
Exactly.
relatives, and they understand we are the threats, because we are going to break the news to the patient and are going to harm the patient. That's what they believe. So they have to understand that we are also with the family. Then only we will be able to talk to the family. I totally agree that the patient has the right to know, but we have to be very careful in our situation while we talk to the family against the wish of the to the patient against the wish of the family. So how to exactly deal with the deal when the patient is not able to eat or not willing for any further intervention like a nasogastric tube? So anybody?
Sir, here the issue was she was not basically so there was many previous history, because here only there was two episodes. First thing, she came for an ortho problem, not for cancer.
Yeah.
It was incidentally found that she got cancer, and after that she deteriorated and she is no more now. And what happened previously was her husband, he came here with urosepsis, and it was a prolonged course. We did him TURP and all the procedures, and he is fine now. And she was in the hospital for 15-20 days during that whole procedure. So she and those people and all, they have not went to hospital for probably for 1 or 2 days for fever or for headache. They would have gone for prolonged days, these things and all, they have not gone, and they're not accustomed to hospitalized environment. They hate hospital. So after seeing her husband struggling with central lines, catheters, everything, she is afraid to come into the hospital, and she is not allowing any of the staff nurse to touch her, even for putting an IV in everything. I was it may be 1 o'clock in the night, 2 o'clock in the night. For everything I need to go, I have to talk to her, and everything I need to do. So she is as she is not willing for, see, she is able to take only liquid diet, not the solid diet, because of the prognatism. She is not able to chew. But her concern is she is not able to take the daily idli, dosas, everything. That was her concern. But she is not able to do all that. Of course, I know that rice tube is not going to help much, but at least in right soup we can give some more thick solid semi-solid liquids we can give nicely in right soup. But she was not willing for any procedures because of her previous experiences in the hospital. So like this, when patients come, what can we do, sir?
Okay. So this is a very difficult situation for the family members as well as for us professionals. What we have to explore is why the patient is refusing. You have told all the reasons because of her previous experiences. You can also ask, are there any other reasons you are saying don't I don't want any interventions? You can explore that. Then rule out depression. Is there any major depression going on now? If there are these things are ruled out, and you have given, actually you have to give all the information to the patient, that what happens, or what are you going to do with the nasogastric tube, and what would be the procedure, etc., etc. And if the patient understanding that, okay, I know that without food I will not survive long, and you have ruled out um, depression, and she tells you that, okay, I know that I have a advanced malignancy, and with Riles tube or PEG my quality of life will be decreased. And that means the patient knows all the information. And uh, in such instances, I think it is our duty to be with the patient, and make the family understand the wish of the patient. um, that's what we have to do. So in this situation, she has a very advanced malignancy. Even if we are going to put a Riles tube, it will not be beneficial for the patient. These are the common situation which we usually face. And in such situation, what we do is, if the patient is not taking anything orally, even liquid or water, we put subcutaneous fluids, subcutaneous normal saline. So we administer subcutaneous normal saline, and we teach the family members how to administer subcutaneous normal saline, which is not very painful.
Yes, sir. But subcutaneous normal saline, what does it actually does, sir?
No, it only gives some water to the body. It is not going to be nutritious for the patient.
So then the next question can we go, sir?
Patient has
No, sir.
yeah.
So what about this, like a parental nutrition, things like that?
So I just want to tell that this patient has a very advanced malignancy with the liver, adrenal, bone mets, everywhere it is metastasized. So what are you going to achieve with parental nutrition? Because when the patient is in advanced malignancy, the cancer cells, which has a very higher metabolic rate, even if you administer something, most of the nutritious or calories are utilized by the cancer cells, and that will not be beneficial for the patient that way. And the cost which is involved, the benefits, are we going to benefit the patient with the parental nutrition? Most probably not. So that's why in advanced malignancy we don't advise for parental nutrition.
Okay. And how do we do this subcutaneous fluids? Like how much we give and
Okay, so it is not like intravenous fluids. You have to administer slowly. So you will put a the butterfly needle, maybe 23 or 24 gauge needle. You can put it into the subcutaneous tissue. If you raise the pad of fat, and then at 45-degree angles, you can insert the butterfly needle, and at maybe 1 ml per minute is the maximum that you can give. So maybe even 500 ml can be given in, you can give it in 5 hours, but usually it will take maybe 8 hours, 500 ml to finish 500 ml, 8 hours should be given. Even 3 pints of normal saline can be administered if you require. And compared to IV route, it is easier to put a family can be taught, and even family can place a subcutaneous needle. Infection is very less.
And it won't cause this tissue bulge and things like that.
There will be some amount of tissue swelling because you are administering it to the subcutaneous fat, and from the subcutaneous in the subcutaneous fat there are numerous blood vessels, capillaries, so it will be absorbed slowly into the capillaries. So if there is a huge swelling, you can stop the infusion for some time so that swelling will disappear. So patient herself, though she is not getting treated in her hometown, she wants to go to her hometown and have a peaceful ending there, and family members are willing to take her back when there is no medical help. Yeah, this is again the question of autonomy, but from our point of view as medical doctors or medical professionals, we think of if there is no medical help, what will happen, and we are worried about that. But if the patient is informed about what can happen at the end of life and what are the sufferings that is going to occur, then with knowing that if the patient and family want to go to her home and die, it should be okay, because when I was young, I even didn't think of dying at home. There was no concept, but when I grow up, and when I have my own house, and now I have my preferences where I would like to die. It's my choice. So I would also like to do this. So it's their choice, but I think you can also prescribe some anticipatory medications, and maybe, as I told you, subcutaneous medications can be administered, midazolam, haloperidol, all those can be administered subcutaneously. So if you can teach the family regarding this, then definitely they can go home with this, and maybe you can be available over the phone to advise regarding any symptom management that is necessary. So the next question, in spite of giving all necessary options, they wanted to take her back to home with suffering and no medical help. How to approach this problem? Yeah, Dr. Gautam, I think the two questions are related, the previous one also. So will such patients discharged under LAMA?
This is not about discharge, because they're also my mother's aunt only. It is not about discharge, but the issue is the statements they used is this auntie, she is right from her married life. She has not moved out of the town. She has lived in the same home for this long, and they clearly told she wants to take her last breath only in that home. She doesn't want to take her last breath anywhere else, and she want to get cremated nearby grounds only. In the they had nearby grounds. There only her cremation has to take place. We know she's going to die, but even then, if at all you can give some medications which can help, you try giving. But her last breath should be only in her home for in which she has lived for so long. And in these things, I was not able to tell anything. I only arranged an ambulance with the staffs, and I sent them back to their home. I don't know how to
the
react.
right thing. I think you did the right thing, because that was her wish, to take her last breath at home. You respected her wish, and if I or somebody else in that position, and I wanted to go home, you should send me. My body is my right, and whatever I want to do, I should do it. You should allow me to do that, then only you will respect my dignity. That's what I believe. Dr. Arsha?
Actually, I was asking this question because I underwent the same situation. But in my mother's case, they were not discharging her because they were saying it will come under LAMA. So I was asking this, such a patients whom we know that they are not going to survive, and suppose they are on NORAD 4 or 5, are they always discharged under LAMA?
Okay, actually, we have many patients here, and some patients, when they come close to death, many patients, some patients request a discharge. Then we usually don't write LAMA. We discuss with them what are the problems that we can expect, and then we will act according to the wish of the patient and family. So I think it's our duty.
Lama may be medico-legally correct, sir, but when we use this term, you are going against medical advice, everything. Probably the bystanders or anyone, they may get offended. What is this? We are going to our home. Why they want to? Because they are already in grief, and we are getting 10 to 15 papers of signed. I don't want resuscitation. I don't want CPR. I don't want ventilator to put. I'm not. I'm going to go against medical advice. I don't want dialysis. Especially in bigger hospitals, we used to get 10 to 15 papers for each and every procedures we used to get. If you're not going to take dialysis, you are going to succumb, and you're not going for the ventilator, you're going to succumb. And is it right to get a LAMA, sir? Probably medical legally it may be correct, but ethically, is it okay, sir?
Dr. Gautam, ethically it is okay, and I think it's our duty to respect patient wish. So actually, autonomy is the overriding principle in ethics. So I think we will have more discussion on all of this regarding end of life care, ethics, communicating, how to manage collusion, etc., etc. We will have a detailed discussion. We have a separate session on this. So I think Dr. Gautam, you did a very good job, and at least you could help her to die at her home as per her wish and family's wish. Ralishmi, I think we will stop.
Yes, sir. So I have shared the feedback link now. Give it a minute, do it, then only leave the meeting. We can see you next Wednesday with a topic on medical ethics taken by Dr. M.R. Rajogopal. Thank you all. Bye.